So that was a very fast minute. I believe that we're live. We are live. So good morning, everyone. It is 10 o'clock on Monday, the 30th of May, 2022. Welcome to the County Council Chamber for this meeting of Staffordshire's Health and Care Overview and Scrutiny Committee. I am your Chair, County Councillor Jeremy Pert. May I remind committee that today's meeting is being recorded, and for those who want to watch back today's session, the recording can be found on the County Council's website. The meeting is also being beamed live for people to be involved and will cut off 20 seconds after the equipment has stopped. All voting committee members are in the chamber in person, and there is a variety of people both in attendance and virtually as our guests. You are all welcome, as is the member of the public in the gallery. Good morning to you. Can I ask our guests, can I thank our guests for their input and so far for their time? Can I also ask that our presenters restrict their opening comments to 10 minutes, please, given that we're going to be very tight on time and we need to use every minute available for scrutiny and evidence gathering. Secondly, can we focus on tangible outcomes for the residents of Staffordshire? Let's use the data and our experience to sharpen the quality of debate and scrutiny so that we can provide assurance and reassurance that things within the health and care system in Staffordshire are going in the direction we would all like to see. So let us start with item number 1, apologies. I have seen apologies from Keith Flunder, I have seen apologies from Richard Cox, and I have seen apologies from Janice Sylvester Hall.
Thank you, Chair. In addition, we've got apologies from Councillor Lynn Hingley and Rosie Claymore. Councillor Daniel Maycock is in attendance this morning as substitute for Councillor Claymore from Tamworth District.
Thank you. So can I welcome our new members from our district and boroughs, Patricia Ackroyd, Lynn Hingley, who isn't with us today, and Mike Wilcox. Can I also welcome our returning member, Bernard Peters, and congratulate the new Vice Chair, Richard Cox, on taking up his appointment, albeit he's not with us today. Can we also note our thanks to previous members of the committee and the previous Vice Chair, Paul Northcott, for their service and commitment, and equally can we congratulate Councillor Northcott on his elevation to Cabinet Support Member for Health and Care. I would like us to put on record our thanks to Johnny McMahon and our best wishes to Dr. McMahon, who was a preeminent GP within Cannock Chase area, was a previous chair of this committee for many years and was a very able cabinet member and cabinet support member for health and care. So can we put on record our thanks to Johnny for the work that he's done over many years for the residents of Staffordshire in relation to health? Are we in agreement? The odd nod would be okay. Feels like I'm going to have to do a bit of prodding today. Okay, thank you for that. So, moving on to declarations of interest. Do we have any declarations of interest for this morning's agenda? Councillor Anne Edgeler.
Thank you, Chairman, and good morning, everyone, and welcome to the new members. Yes, I'm Partner Governor in the Midland Partnership Foundation Trust from the county. Thank you.
Bernard, good morning. Welcome. Nice to see you.
Good morning, Chair. I'd like to declare that I am Staffordshire County Council's local authority appointed governor at UHDB.
Thank you for that. Any other declarations of interest? No, I will move on. Can I just confirm for the minutes that we are quorate?
Yes, Chair, we are quorate.
Thank you. So let us move on to the minutes and item number 3. Can I ask if the minutes from the meeting of Monday the 11th of April 2022, for those of you who were there, are an accurate and true record? There's a proposer, I've got a seconder, and are we all in agreement?
Yes, Chair.
That's fine. I'm seeing plenty of nods, so that's fine. I'm reliably informed that all actions have been followed up and all information received to date has been circulated around committee. In terms of one other response, we have had a response to a previous action relating to Wallis Quarry, where we've received a response from the Minister in relation to the Environment Agency's non-attendance at our March meeting. And they've made the point that the Health Security Agency is responsible for health matters, which frankly I found particularly helpful and enlightening. So on that basis, I don't think there is anything else to report. So with committee's approval, we'll move on to item number 4. And we are welcoming Helen Ashley, who is the report author of number 4, to talk about... Sorry, Paul, I missed that you were with us. I need to pay more attention or have a bigger screen, one or the other. So, Paul, good morning, welcome to you, and welcome to everyone else online as well. Don't let me forget everyone else. Can I hand over to you, Paul, and also to Helen to take us through the elective recovery, please?
Thank you, Chairman. So I'll just give a brief overview of the report that's contained within the pack this morning, and then both myself and Paul are very happy to take any questions that members or elected representatives have. So I suppose just to be clear from the outset that the update today is in respect of the 3 main provider organisations that serve the population of Staffordshire and Stoke-on-Trent. My role specifically here today is in respect of my role as planned care lead for Staffordshire and Stoke-on-Trent ICS. So I am representing and have information in respect of University Hospitals North Midlands, Royal Wolverhampton Trust and University Hospitals Derby and Burton. So just a bit of context before we start to talk about elective recovery. We know, don't we, that we continue to live with COVID circulating in our communities, and therefore for us as an organisation we still continue to have significant, though reducing, numbers of COVID patients in our hospital beds, and that's the same for nearly all NHS acute trust providers at the current time. But despite of that, we're very much now wanting to look forward and to turn our attention to elective recovery and making sure that those patients who, as a result of the pandemic and some of the constraints that we had to put on our services, have now been waiting far too long for their planned surgery. So the NHS has set itself a number of expectations specifically for 2022-23, and today I was going to specifically focus on patients waiting more than 2 years and 104-week waits and 78-week waits. So I'll talk a little bit about our challenge in trying to treat those patients, and then more broadly about our approach as an ICS to elective recovery. So the first milestone that we face as a set of acute providers is eliminating the number of patients who've waited more than 104 weeks for their surgery by the end of June. And that is something that we're all absolutely committed to, but comes with it a number of challenges. And I think when you look across the 3 main providers, Royal Wolverhampton has very low numbers of patients waiting 104 weeks and is absolutely on track to eliminating those at the end of June. Given their geography, they are well supported by the other 3 Black Country NHS trusts, and therefore have been able to secure capacity across all of those providers to make sure that those patients are treated. For UHM and UHDB, that's slightly more challenging. Both trusts are specifically struggling with ensuring there's sufficient capacity for bariatric patients. Derby Burton has secured some capacity in the northeast for those patients to undertake their surgery there, and for UHM we've secured some capacity in the independent sector, Worcester way, I think, and so we are working with those organisations to try and get those patients treated before the end of June. UHM is also struggling due to the complexity of the patients to treat all of its spinal patients before the end of June, but very much continuing to focus on that and to identify any capacity we've got or with other organisations to address that. And then additionally, the target of treating all patients by waiting 78 weeks by March 23. At this point in time, UHN does not have plans to be able to eliminate all of those, but that's something that Paul and the team are still working on and hope to resolve within this next month, such that we can assure ourselves and yourselves that all of those patients will receive their treatment. More broadly, our approach to elective recovery is to look at things in three buckets, three work streams. The first is that of demand management, so to make sure only those patients that need a referral into hospital receive a referral, and wherever possible we offer alternatives to patients and seek out alternatives if a referral to secondary care isn't what's needed. And within that work stream we're also trying to focus on making sure that those patients who have already been referred for surgery are fit for surgery when their surgery comes around. And patients who have waited more than 2 years, undoubtedly their overall health will have deteriorated, and the condition to which they were originally referred may well have also deteriorated. So working with our clinical teams to make sure that the patients are fit for surgery, and that also there is an early review of them before they come in for surgery to make sure that we can optimise their care. The second area of focus is that of existing capacity, so making sure that the capacity that we have available to us is best used, and that's both NHS capacity and independent sector capacity. So we have significant capacity across Staffordshire and Stoke-on-Trent already. We are well served by the independent sector. We know that there is new capacity in terms of Beacon Park, which is available to us as an NHS, which undertakes surgical procedures. So making sure that we use as much of that as possible, and wherever possible we're delivering to national standards in terms of throughput of our theatres and our beds. The final area that we're looking at is new capacity, and I've referred to in the paper both UHNM, RWT and UHDB are receiving additional capital monies to increase elective capacity. For UHNM, that's about increasing capacity at the county hospital site. RWT are looking to increase capacity at the Royal Wolverhampton site, and UHDB, though it doesn't sit strictly in Staffordshire, have resources to be able to increase capacity at the Derby site, which undoubtedly in turn will create more capacity for patients in Staffordshire itself. And happy to take any further questions on that. The final point that I would make, Chair, is in respect of health inequalities. We're really clear that over the course of the pandemic, health inequalities will have broadened. As a set of acute hospital providers, it isn't information that we easily have at our fingertips. So where we are currently is we are looking to draw together the information that says, have we broadened health inequalities? Are there certain patient groups that are now waiting longer than they would have done historically? And to then use that information to inform how we deliver services. But that's very much in its early days. So hopefully that's been helpful in terms of a summary of the areas that we're focusing on, and now happy for either myself or Paul to take any questions. Thank you.
Thank you, that's useful. So, Thomas.
Yep, thank you very much. You mentioned there was a target of March 23 to get the 100-week waits, or have none over 100 weeks. So I've got a bit of a double-pronged question on that. And that sounds scary, I think, to anyone in here, 100 weeks waiting for something. So what now, the pandemic's happened, what's the core underlying reason why it's going to take that long to get a 100-week wait down? And could you give us a bit of a flavour of what kind of procedures people are waiting for that long?
Yeah, absolutely. So just for clarity, we need to eliminate the number of patients waiting more than 104 weeks by the end of June, and then 78 weeks. Neither sounds particularly palatable, by the way, but I just thought I would clarify that point. I think I've articulated those patients who we're struggling as a system for in terms of 104. So people underweighting complex surgery that might require more than 2 surgeons, perhaps an all-day operating list in order to be able to have their surgery, and also some of those more specialist services where we only have a limited workforce. I'll ask Paul to come in a bit more detail, perhaps in terms of some of those specialty challenges, but I suppose what I would say is that there was a period during the first wave of COVID where we were asked to stop all elective operating, and only for those patients who were urgent, so emergency, or being treated for cancer were given their surgery. So as a result, we've had a significant backlog of patients build up. We will, of course, across all provider organisations, do everything that we can to fast track that and to bring patients in as quickly as possible, but we have limited resources, and therefore inevitably it is going to take a while to treat those patients. And then just a final point, I would say that not all specialties, well, no, a number of specialties going into COVID already had long waits. And so if you overlay that period of not operating, then that's just accentuated that. But I don't know, Paul, did you want to talk specifically about any of the specialties?
Yeah, hi, and good morning, everybody. I mean, I think the challenge is we've got a growing urgent number of operations at the front of the pathway, and we've got a shrinking number of patients waiting a long length of time for their non-urgent procedure. And so our whole ethos is obviously trying to keep those that require urgent operations going as much as we start to see the long waits also start to reduce. So it's not just an A plus B, because they are different complexity. They require different amount of time. Obviously, the additional theatre capacity we've now got down at Stafford Hospital. We've got all the theatres now up and running at Stafford. We've got new theatres planned for the end of the year. This will help us to start managing those two groups of patients in a more timely way. As Helen said, some of our challenges, particularly the complex spine or the bariatric, had challenges before going into COVID, and the complexity of getting an all-day list, 3 surgeons together, requires a lot of resource to be able to do that. But we're hoping we will be very, well, we're not hoping, we know we will be very, very close to zero for those patients waiting over 104 weeks by the end of June.
Thomas, do you want to come back?
Yes, please, yeah. So I don't think you really answered what's the core reasons? You say specialism, is it the workforce to do it? Is that the issue?
So workforce is inevitably a constraint, isn't it? And I suppose going forward, one of the things that we need to be mindful of as everybody is looking to physically increase their capacity, that requires a workforce to be able to run that capacity, don't they? So for surgery, as you would expect, 2 main groups of staff that are a challenge to us. The first in respect of theatre staffing, and nationally, as everybody tries to increase their theatre capacity, we're all looking for additional theatre staff to be able to serve that capacity. So we are looking at innovative ways of doing that, and certainly across a number of staff groups now, we've been looking at international recruitment. I would say predominantly the medical and the surgical workforce is less of a constraint. I'm looking at Paul now to nod, because actually, if we can redirect their time, they have flexibility within their job plan to be able to do more operating if we require. But I would say the main constraint is probably theatre staff. As Paul said, we've already been very successful in terms of recruiting to a number of additional theatre roles. We have opened new capacity at County Hospital, and I know that RWT and UHDB are both doing the same.
Anything thrown up from that? Can I just pick up two issues, please, Helen? You mentioned that UHM is going to create their plan or finalise their plan by the end of the month. I'm assuming you mean June. Would you be kind enough to share that plan with us so that we have overview of that, please?
Yep, absolutely we would. We're required to, I think all organisations struggled with achieving all of the standards by the end of the year. So as an NHS in its entirety, we're required to resubmit that during June. So happy to share that with you then.
Thank you. And second of all, I think it'd be useful just to see what the forecast is. We've obviously seen the historic picture through some of those charts. I think members would be keen to see that progression towards zero weights in June and zero in March 2023 above those timelines. But if you could share with us the forecast by specialism, again, I think that would probably just help us be able to focus in on the right areas.
Yeah, happy to do that. I think Paul wants to come in on that point, Chairman.
Sorry,
Yeah,
Paul.
yeah, Chair. And I guess I suppose we've painted quite a gloomy picture in our 10 minutes so far, because it is, for those patients waiting a long time, it is a very gloomy picture. But we are almost certain that we will nearly eliminate all of the 104-week waits by the end of June, other than those patients who have deferred their operations for personal reasons or from the complexity. And that puts us in a really good position then to move towards 78 weeks by the end of the year. So and just to answer one of the points the previous councillor made, all the way through COVID, those routine operations were slowed down, and in vast periods of time there was no routine operating, because the theatre staff were supporting our critical care response or the wards. So we've had a general slowing down of activity, and since February we are now back up to over 100% of our operating. I've just had the figures come through while we were talking. We're back up to over 100% operating in terms of the number of patients that we've got going through our theatre complex than we were in 1920. And that's a really good reassurance mechanism for us that we will be on track for the 104 and the 78-week waits by the end of the year.
Thanks, Paul. Just before I bring in Charlotte, can I just check in terms of your comment that you're running at over 100%? Is that across every specialism?
That's across our theatre capacity as a whole. So some will be operating more because they've got more of a challenge, but our theatre complex in its entirety is now more than 100% than it was in 1920 in terms of the total numbers going through.
So how do we get to see the ones that are significantly under the 100%? Not marginally under, but significantly under?
Chair, I think they'll be under 100% because we have moved away from giving them actual capacity to support those that are more challenged. So the important bit is that our theatre capacity is being used at full throttle in order to treat our patients and those that need it, rather than specialty.
Thank you. Charlotte.
Thank you, Chair. A couple of questions. In paragraph 4.1, I think the suggestion there is that patient choice is a factor in delays. If you could please explain what that is and why that's happening. And secondly, at 5.2, you're talking about exploring local approaches to reduce unnecessary outpatient appointments. Could you please focus on what you're doing with GPs? And I'm not quite sure I really understand the advice and guidance issue, so if you could explain that as well, that would be useful. Thank you.
Yeah, no, that's absolutely fine. I suppose, we need to be open and honest about the patient choice issue, because actually what that really is the NHS being pushed very hard to deliver an agreed standard at an agreed date, such that when we then say, so we need to treat all patients by the end of June who have waited more than 104 weeks, and we ring a patient and say, we desperately need you to come in for your treatment in June, and actually there might be circumstances which mean that they don't want to, and that's absolutely right, and say, no, I don't want to come in until July, I've got a holiday, I've got something else planned. So actually it's very artificial as far as the patient's concerned, really, to push for something at an agreed date just because that's the expectation that we have or they have nationally. So normally it's just around, it doesn't suit the circumstance of the individual patient, and we'll defer that and they'll be treated later in the year in line with their own circumstance.
If I can just explore that a little bit further. So if you offer someone, say, a date in June, they say, well, we can't do June, do they go further back into the waiting list, or do they just slot in again when they're back from whatever
yeah,
event
as Paul said, we try to manage the patients in two ways. The first is in respect of their urgency and their complexity, and then the other is the length of time that they've waited. So they absolutely wouldn't get pushed to the back of the queue just because they chose that. Just in respect of outpatients, we are working very closely right across Staffordshire with all the local GPs and making sure that when we're looking at changes to patient pathways and things that would better support them, we're looking across that as a whole. So absolutely working with either the primary care networks or local GP practices to make sure that we can develop services that mean that they don't need to refer their patients. Specifically on advice and guidance, I always describe advice and guidance as a service that means that the clinician have the conversation, but the patient doesn't need to be referred. So it's a conversation between the GP who says, I've seen a lady in clinic this morning. I don't think I need to refer her, but I would like some advice in respect of her treatment. And so it's a clinician-to-clinician conversation, which doesn't mean that the patient has to go along to an outpatient appointment only for the consultant to say, there's nothing I need to do for you, I can refer you back. So it is meant to be a more efficient use of the clinician's time, but as importantly, a better use of the patient's time so that we're not referring them unnecessarily.
Are you aware of many GPs requiring patients to fill in triage forms before they will see them face to face? Because you were talking about inequality of access and so on. And obviously, if you could fill in a triage form online, rather than coming and presenting at 8 o'clock at the surgery to fill in your triage form before you can see a GP, because I've certainly had people come to me complaining about that, and that does worry me, particularly for an older age group perhaps that are not online, and the fact that they see this as a huge imposition when actually all they want to do is to see a GP face to face. So I just wondered if you were aware of that, because certainly in terms of accessibility, I advise that particular person to change her GP immediately. I hope that she does that.
I'm not aware, and I'm sure it's something I've noticed. Tracy's just come on screen. I was just going to say, Tracy, did you want to comment on that from a CCG perspective?
Yeah, absolutely. I'm not aware about people having to fill in forms, turning up at a practice to fill in forms, and I will take that back. And if Councillor Atkins, if you want to let me know which practice that is, we can follow that up with the primary care team. To say that in GP access, we know there's an issue with GP access. There's a lot of work being done. It's quite variable. And what we're finding from our public is it's quite variable, their experiences. Some people have very good experiences. Some people are really struggling with access. So I'm quite happy to look at any in particular issue, see what's going on in that practice and find out what's going on there. Because if people are being asked to walk down and fill in triage forms, it just doesn't seem quite right to me. So, but I'll take that back and pick that up.
Sorry, can I just interrupt? Can we have one meeting, please? If there are other discussions that need to happen, can we do them outside the chamber, please? Charlotte.
Yeah, I think the point is that if you could sort of fill in a form online, then that might not be such an imposition, although it's bad enough. But the fact that you actually have to go down to the surgery at 8 o'clock in the morning to fill in your triage form, and you're not even going to see the GP, is a bit much. I mean, we are talking about people who need medical advice, so therefore one assumes that they're not going to be 100% fit. And I do think that it is unacceptable. I don't go to see a doctor very often, so I don't know if it happens in my surgery, but it certainly happens in one in Leek.
Councillor Atkins, if you let me know the surgery, we'll pick that up, and I'll pick that up outside. Thank you.
Thank you, Tracy. Anything else, Charlotte? So, Bernard.
Thank you, Chair. I remember how hard the staff worked during the pandemic, and there was some dreadful stories about exhaustion and absolutely flat on the back, as it were. I just wondered, with the model you've described to us today in terms of the recovery plans, are the workforce geared for that? Will they find themselves over-pressured again and perhaps be back to something like, hopefully not exactly the same as they were when they were working during the pandemic? Because I understand there was a lot of work done to help people recover from that pressure, which took them out of the line for some time. So how is that going to be addressed? What are the workforce saying to you about the plans that you've shared with us today? Has it been communicated to the workforce?
Thank you. Yeah, I mean, clearly, the support that we put in during the the pandemic continues. So that support that we offer to either individual members of staff or to teams is still in place, and we're very well supported by our colleagues across the ICS, so be that Midlands Partnership Trust or Combined Healthcare, in offering some of that well-being support. I think the first thing I would say is that this isn't the same for all staff. Of course it's not. But what has not helped in terms of some of the burden that we've put on our staff and their own well-being is the fact that we've asked them to work in areas that aren't the one that they were originally employed in, or that they don't necessarily feel the most comfortable in. So just by returning those members of staff to their own department, clearly that has a positive impact. And I would say the other thing, it's not just about the department that they work in, it's about the team that they're used to working with. So putting theatre staff back in the team that they are most comfortable working with and chose to work with in the first place does have a positive impact. We continue to have a dialogue with our staff about our future plans in order that they're aware in terms of what we're trying to do. I think, as I articulated previously, we recognise that we will need more staff, so we're not just asking our existing staff to work harder, and we've been really clear, and I know Paul's been really clear for UH&M that this isn't just about staff working harder. In some ways it's working slightly differently, but it is about having additional staff to be able to do that. Paul, did you want to comment on anything further in respect to our approach to staff?
Yeah, I mean, what our staff have told us previously, Councillor, is they just want to get back to doing what they were trained to do in the environment they were trained to work with, the people that is their team. So in particular, our theatre staff, bringing them back together, doing the job that they've done for 5, 10, 15 years before the pandemic I think is the single most important bit of our plan, that they're doing what they want to do. And we continue to engage with them, sort of the Chief Executive and the Medical Director at County Hospital today, engaging the whole of the county hospital staff on what our plans are and what we're doing. So we're hearing exactly from them what they feel and what they think about our plans. So you are right, the effects of the pandemic aren't over in the hospitals. Yeah, we're still wearing masks. That's still how it is. But supporting our staff to make sure we look after them has been and will be key to all of our plans.
Anything else, Bernard? And obviously we would want, I'm sure, to pass on our thanks to all the work that is being done to bring forward the elective. Phil Hewitt.
Thank you, Mr. Chairman. My apologies for being late. I was actually having a hospital triage appointment out in the corridor, so it seems quite appropriate. Because I came in late to this debate, Mr. Chairman, if I'm on the wrong tack, I'm happy you put your hand up and stop me. We're talking, excuse me, obviously talking about telephone appointments, talking about triage appointments. And I wonder, this is approaching it from a slightly different way, for somebody who's had great health pretty well 99% of his life in the past 6 months, has not been unchallenging. I'm well on the mend now, but it's not been unchallenging. I've had huge amounts of telephone calls and seen doctors. I've never at one stage thought that when a doctor wanted to see me, he's seen me. I've never at stage like the telephone call I took in the corridor this morning, that I needed to drive to Burton Hospital to see the person that was on the phone, because the reality is it was all about giving me some advice and things I need to do when I go into hospital in a few months' time. So I wonder, and this is because I appreciate that everybody hasn't got my experience, I appreciate that some people have had problems, but I wonder whether the cultural change, we're not messaging it well at all. You don't actually need to see a doctor, every single time. Now, from a personal point of view, as I'll repeat, when I've needed to see a doctor, I've seen one. When I haven't, but I've understood that it was just a conversation. So I wonder whether we're just not getting the messaging right, that people think they ring up and they have to see a GP or a doctor every single time. From my experience, you don't. Now, I'm sure doctors and clinicians get this wrong, and there are times when they should have seen them. When my arthritic knee was playing up, they saw me, quite right too, it was hurting. And but when I had other issues, they didn't. So the challenge for me is the cultural change, Chair, and the challenge is whether the messaging is getting across.
So I can see a couple of people who want to speak on this. I think, Helen, you want to speak, and I think Tracy wants to speak.
Yeah, thanks. So I think what I would say in the first instance, I think you're right. I think unfortunately, and we saw this in so many different areas of life, didn't we? When the COVID pandemic hit, we all immediately changed the way in which we delivered services or offered things to the public, and you see that in many different ways of life. And I think, unfortunately, having made some of those immediate changes, we didn't always get it right. And to a certain extent now we're in catch-up in terms of that messaging that you just talked about. And of course, if you don't need to come to hospital and you don't need to travel to see your GP, you shouldn't have to. And we should always aspire to make sure that the conversation that you're having in the review is with the most appropriate clinician. In that first instance, I don't think we can all hand on heart say that that was the case, and undoubtedly, you know, as acute hospitals, we'll have offered telephone conversations where perhaps on reflection a face-to-face conversation would have been right, or a video consultation. And I think we're still learning from that and trying to make sure that actually we have something that suits everybody, because digital doesn't suit everybody and telephone conversations don't suit everybody. So if it's somebody who's struggling with capacity, having a telephone conversation doesn't necessarily work if that doesn't engage their carer or support worker. So we're constantly learning, and hopefully moving forward, we will have something that is more flexible and more suitable to everybody's needs than what we previously had was bringing nearly everybody. I think GP practice, we're already doing some of this, hospital less so, but hopefully we'll have a more flexible model going forward.
Tracy, did you want to come in?
Yes, thank you, Chair. And you're quite right to raise the issue around the communications, and we've just started, it's this week, a campaign, especially around primary care access, and not only about how it's changed and trying to catch up with how things have changed to try and explain that to the public, and it's also about the different roles that are in primary care as well. So, for instance, in particular myself, I filled in a form and I've got to see the physio. I don't need to see the GP. And they've said, can you please phone and make an appointment with the physio? And I think we need to explain to our public as well that there are the different roles within the practice, and actually seeing a GP then being referred to the physio is actually causing more handoffs for individuals. So we just need to engage with our public now and show them the different roles that we've got in primary care, how things have been changing and how their care is changing. But we do have to be mindful, as Helen says, a digital solution doesn't suit everybody, and we need to take into account people's needs really when looking at those solutions. So that's something that we're launching this week. So you're quite right, Councillor Hewitt. We do need to play catch up a bit with the public. So thank you.
Phil, do you want to come back?
No, I don't. I mean, maybe I do. I think there are some challenges there, but I don't, from a personal point of view, it's not 100% criticism, and that's what concerns me. I hear nothing but I can't see a doctor, when actually there needs to be a balance. I don't think the doctors get it right every time. I genuinely don't. If they did get it right every time, we'd all be immortal, wouldn't we? Live forever. That's a thought. But yeah, it is the messaging. Thank you, Mr. Chair.
Just following up from that and just taking Chair's prerogative. Obviously, with any cultural change and with any change of skills, particularly in terms of communication, not everyone has those first off. And, you know, what are you looking at in terms of training and development? Because, you know, for some this might feel an alien place to be, but obviously part of a critical part to the patient journey.
Chair, did you mean before I respond, did you mean in respect of patients or our staff?
Training for the staff.
Okay.
I think sort of, you know, residents generally migrate to something they feel comfortable with, and they just need to be nudged in certain cases. And if they're obviously not comfortable, they don't want to go down, you know, maybe the digital or the video route. But I was thinking more in terms of staff, because they're the key enablers.
Absolutely. And I suppose I'll just go go back to, you know, some of our staff have been using these types of technology for some time, sometimes communicating between themselves, so as part of team-to-team conversations, but not necessarily in respect of clinician to patient. So as you would hope, we've been pushing digital solutions across the NHS for a good number of years now. So the idea of using this technology hasn't necessarily been alien to them. But what we've tried to do, always tried to do, is to go where there is energy and enthusiasm to do so and where it makes sense. So certainly for UHM, one of the first groups of patients that we looked at was our cystic fibrosis patients, who you would absolutely expect not to want to come on site, into a hospital site, where a respiratory condition is in danger of being transmitted. So we've tried to go with patients and staff groups that already have that positive attitude to it, and to bring along those other groups over time.
Thanks, really useful. And does that include multidisciplinary team meetings with the patient rather than, you know, because quite often you find that you need more than one discipline rather than...
I'd have to come back to you on the extent to which we're having, certainly for some patient groups, we would be doing that, but I suspect it's not as widespread as you would wish.
I'd love to see that data, yes please. I think you hit that straight on the head. Angela.
Thank you very much, Chairman. My question really relates to County Hospital. I'm really pleased to hear that County Hospital are going to be helping with this problem. And I wanted a little bit more feedback how that's going to work. Now, I understand what Paul's just been saying, that he's had a meeting with the staff this morning at County. Could he share with us some of that input that was taking place at that meeting as to how staff reacted and to how it's going to work? Thank you.
Paul, do you want to go first and then I'll pick up?
Yeah, so it's not me, Councillor, it's the Chief Exec and the Medical Director who is having them. Actually, it's a series of meetings that they're having. But effectively, we're looking to reuse the space at County Hospital in a different way that will allow more operating to happen down at County Hospital, either through the estate being revamped and additional beds being put in, or, as I said earlier, the day case facility that's being put into the hospital. So it will play a massive part in our elective recovery, because our plan will be that County becomes almost a sort of a planned care centre of excellence in terms of elective operating. Choosing my words carefully, recognising not all of this is yet fully wrapped into a complete business case.
So just to expand on that just a bit, if I may, we recognise that currently patients from the local geography aren't able to get the full range of surgical services at County Hospital, and to a certain extent that will always be the case, because County Hospital is unlikely ever to do major complex surgery because the infrastructure isn't necessarily there to support. But what we are trying to do is to expand the range of surgeries that you would expect at a district general hospital, and by making sure that we've got the right facilities to treat those patients. So currently, regardless of the type of procedure you need at County Hospital, it's undertaken in a main theatres. So what we're trying to do, and a lot of other hospitals will already have this, is to create sort of day surgery facilities that mean that we can get a higher throughput of patients through those, but also the experience is quite different. So we're not bringing people in for a major surgery experience when the surgery they're having isn't major. So it's about trying to offer more of that surgery more locally to the Stafford population.
You want to come back?
Thank you, Chairman, and thank you. We'll just keep our eye on the situation. Thank you.
Just two things. To be clear, it is an increase in facilities and options for elective surgery.
In the first instance, yes.
Thank you. And for a sense of balance, I know there's some investment planned for RWT. We've not really talked about that. And as a county-wide committee, I think we probably would be remiss if we didn't. Do you want to just reflect?
Absolutely. So investment to support 2 further operating theatres at Cannock Hospital in order for the patients who live in the south of the patch. Cannock Hospital has traditionally focused on orthopaedic, but my understanding is that that's a broader offer. And then I suppose in true balance terms, I think that the Queen's Hospital site in Burton has already had significant additional capacity invested in, and the majority of that is now fully functional.
Thank you, very helpful. Jill Hood.
Thank you, Chairman. I'm going back to Tracy and her primary care campaign, which I'm delighted to hear that there is that it's going to launch. I think you said this week, Tracy. I would ask, and I'm going on to Charlotte Atkins' comments about triage, that the campaign has, even if it's only a small focus on the elderly, who really, really struggle with digital. And, you know, if you were to say to one of my ladies at Age UK, Age Concern, you're going to a centre of excellence, they'd think they were going for a special offer at the local supermarket. You know, we've got great hospitals, we don't need to have all these key phrases. But it does concern me about the triage. For an elderly person to actually ask for a doctor's appointment is huge. They're of a culture and an age where they don't go to the doctors. I think, you know, that this age thing, we have the younger population who will have already Googled their symptoms. They'll pop into the doctor's surgery, they'll tell them what they've got, what medication they want, and then they'll pop off home. Our elderly don't do that. They're extremely frightened of new things. And in my division in Stone, we have an enormous elderly population, and one of the practices in my town actually uses the triage system, which I think is unfair because it takes so long to get an appointment. So I hope that you'll, Tracy, give some consideration to the elderly. Thank you.
Yeah, thank you, Councillor Hood. And yes, we have to give consideration to all members of our population, don't we? And I think where we've seen some of the issues, actually, it is the elderly that have struggled. Now, you know, I don't want to be in any way discriminatory because some of our elderly population are using the digital models, but we need to make it accessible for all, whatever age or whatever issues. So yes, your point's well made, and thank you. We will take that into account.
Do you want to come back? Anyone else want to? Bernard, Queen's, no doubt.
Pardon? No, thank you, Chair. When we were talking about communications earlier and the importance of it, I just bring the conversation back to Burton-on-Trent, if I may. A very, very diverse community, and if you overwrap the ICS pieces of work around that, are you convinced that the reach that you have, you're getting through to people about this change where English isn't their first language? What are you doing to address that?
Tracy, I know Tracy's comments.
Yeah,
I don't know, Tracy, did you want to comment?
Yeah, and you're quite right, and we've learned quite a lot through the COVID vaccination programme, and thanks to elected members and our community leaders and different faith leaders, we've worked with them because we had to get the messages out around vaccination. So we've reached into the communities in ways that, you know, sadly we probably didn't do before. So there's been quite a lot of learning, and I certainly know some of the community champions that work on behalf, especially Asian women, and different areas like that, specifically in Burton. So yes, we do have access. We're always looking to improve, but we did learn a lot through the COVID vaccination experience in who we need to access. But it's a good point, and we do have to work with others because it's not necessarily people will want to talk to us, and obviously English may not be their first language. So yeah, we have that experience, and we're using that in the campaign going forward as well.
Chair, if I may. The concern I have as an elected member is that any group of people may get left behind because of a language difficulty, perhaps. And that really, to me, is not acceptable. So I'm reasonably assured by the work that you've described to us, but may I ask that you keep a focus on it, please, particularly in Burton? I suppose Stoke as well would fall into that category, wouldn't it? Thank you.
Yeah. Yes, there's some areas as well, and also it's not just about the English as first language. We've got sensory impairment and different groups that we've had to work with, and absolutely we need to carry on doing that and take the learning that we've got and to continue with that. But thank you, your point's well made. Thanks.
Thank you. Can I just ask a couple of questions? Obviously, if we're reducing the 104 and 78-week weights, that means that effectively there is more capacity than supply, so to speak. And are we going to hardwire into the system the additional capacity so that actually, you know, we actually don't talk about, you know, 2 years worth of waiting. Instead, we talk about weeks worth of waiting, and it is sort of single figures? Or am I living in la-la land?
I wouldn't say you were living in La La Land, Chair, but I would say we'd all be delighted to be in that position, and it's not a position that we're currently in. I suppose the biggest challenge that we face, as you say, is treating those patients who've waited. The challenge that we have is making sure that we make that as short as possible, and it's not currently clear to us how long that will take, but absolutely as an NHS we need to get back to patients waiting no longer than what the NHS Constitution said that they were entitled to wait, so those 18 weeks. And I think it's fair to say that a good number of organisations weren't at that position prior to COVID. If we ever end up in a situation whereby we've got too much capacity, I'm sure we'll be delighted to have that problem.
I think, though, it's worthwhile having an aspiration to get down to zero, accepting that we'll never get there. But I think unless we do, I don't think any wait is acceptable if you're the patient waiting. And
I agree.
And you know, I think keeping the capacity to get to that point, albeit it might take many years to get there, would be a worthwhile discussion.
Absolutely, and just on that point, I think during the course of the last 2 years we've developed much closer working relationships with the independent sector, and so very much looking to continue to work with them for them to support NHS patients. Historically they've done quite a lot of that for us, but we have worked a lot more closely in this last 2 years than we ever have.
You mentioned the independent sector. Anyone who's a reader of the papers will have seen some comment nationally on the independent sector. Can you give us assurance that you have used the independent sector as far as you possibly can?
I think I recall, I think I've been to a scrutiny committee previously and talked about the amount of money that we spend in the independent sector, and isn't it high? The NHS locally has always used a lot of the independent sector capacity, and certainly the Nuffield in the north of the county has always treated significant numbers of trauma and orthopaedic patients for us. So we'll continue to do that, and I don't see that changing in the foreseeable future. And an independent sector part is happy to work with us.
Thank you. Did I see, Paul, that you wanted to just add anything? No. Okay, thank you. My final question for the morning on this one is, I'm aware that when the critical incident was called at UH&M over Easter, I understand the reasons for that as well, but effectively my understanding is that the flow through the hospital was phenomenal. What lessons can we take from that and apply them to the recovery of elective?
This absolutely is a question for the Chief Operating Officer at UH&M.
Thank you, Chair. So, Chair, the system declared a critical incident, not just UH&M. And actually what we've learned over those particular 4 days were, it wasn't one big thing that actually happened. It was lots of additional effort from our teams. So our community rapid intervention scheme took more patients. Our ambulance service diverted more patients. We increased our front door decision makers above and beyond. So we've taken all of that learning and we're applying it for this bank holiday coming as well to ensure that we continue our flow through the hospital. Like you say, we went from a truly worrying time that week going into Easter to overall a much better Easter than we, in fact, and indeed the NHS nationally was expecting. But it was additional effort. It was small things rather than one large thing. And we have continued with that work since Easter. And overall, our performance across the system, not just in the hospital, but with our colleagues in NPFT and our colleagues in both councils, we've seen an increase and an improvement in flow.
Thank you, very useful, and no doubt something we'll come back to again in the future. Any further questions from committee? There isn't. So just let me summarise where I think we've got to this morning. First of all, I think there was a clear indication that all 104-week weights will be eliminated by June of this year, 78-week weights by March of next year. There's additional increases in investment planned for both Cannock Hospital and Stafford Hospital to increase surgical options. Thirdly, there's a recognition of the importance of staff to deliver these and to pull in additional staff, particularly specifically for theatre staff. And a recognition of the change of the ways of working and streamlining patient touchpoints. And actually there is a real positive in terms of the way those patient communications have been made. Is there anything that committee would like to do? I think we should note the report and just hold a decision whether we want to see further details as time progresses. Otherwise, I'm going to suggest we thank Alice, that we thank Helen, Paul, and Tracy for today's input and wish them well in what they're doing. Are we in agreement with that course of action? Seeing plenty of nods on that basis. Thank you. You're welcome to stay. You're welcome to go. But otherwise, thank you for your input to this morning's debate, which has been very useful. Thank you. So let me welcome to the Chamber Tony Bullock and Joanna Robertson. Tony, do you want to introduce yourself and the rest of your team, and then take us through? We haven't been through in detail your presentation, so I'm assuming that's what you're planning on doing this morning. How long do you need for the presentation?
10-15 minutes should be fine, I think.
15 is fine. Thank you.
Great. Hi, and it's really nice to see everybody in the flesh. This is my first meeting like this for a long time. It's really good to see some friendly faces I've not seen for a while. So for those who don't know me, my name's Tony Bullock. I'm part of the Public Health and Prevention team here at the County Council, and my colleague Joe Robinson is on the screen above you. Okay. Do we know, are the slides loaded onto a system?
That's a good question, and not yet. We will find a way of doing that. Just bear with us. We have them. We're with you.
Fabulous, thanks. If you could move to the first slide, please. So we're here today to talk about the integrated lifestyle services, which is things like smoking cessation, weight management, and we'll go into a bit more detail about that. So go through a bit of background to give you a flavour for the current contract, what went well, what didn't go so well. This contract comes to an end in March next year. So the key part of the discussion really is to talk about our proposals for next year and get your input on that. If we could move to the next slide. So the current contract's operated by an organisation called Everyone Health, who you may be familiar with us. They've been delivering this for us since April 2018, and the contract's value varies from around 1.5 million to 2 million, depending on results. It's partly a payment by results contract. They deliver weight management services, physical activity, smoking cessation, social isolation prevention, falls prevention, NHS health checks and a few associated services that make all those things happen. The service has been primarily focused on 158 lower super output areas, those parts of the county with the greatest health and care needs. We very much try to target those services at the people that need them most. What that means is that eligibility is restricted. To be able to do that, we haven't been able to make the services available to everyone, although that's varied at different points in time since the service was first commissioned. If we could move to the next slide. So what we found that the service has worked really well. The service itself, we've been very happy with the service provider. The quality of interventions has been delivered well. The service user feedback has always been great. They responded really flexibly during the pandemic. They got involved in a much wider range of activities to support the pandemic when services were reduced. We've seen good uptake of some services such as weight management and smoking cessation. But the key challenge has been the eligibility restriction that we talked about previously. And that's resulted in low take-up for a number of the interventions that we provide. If we could move on. So that gives you a flavour, hopefully, of the size and scope of the service. They've delivered, or they've surpassed the outcome targets for each of the interventions. What you can see there is a huge amount of variability in terms of the throughput or activity. Weight management last year went extremely well. There was additional funding came from central government that meant we could open up the eligibility restrictions and make that available to anyone over the age of 18. And that resulted in a great take-up of the service. It was very easy to promote. It was easy for GPs and other referrers to send people to the service. In other areas, particularly falls, the uptake has been a lot lower. Smoking, over 1,000 people is good, but there's an awful lot more people who could potentially benefit from the service. So as I say, I think the best way to characterise it has been that good quality, but low take-up by and large. If you could move on, please. So the wider context, our strategies as public health teams changed an awful lot over the last few years. Services obviously are important, but there's lots of other ways that people can achieve outcomes. People can do things for themselves. There's lots more information, advice and guidance available than there was in the past. Our partners have got a role to play in achieving our outcomes, and communities themselves can do an awful lot together as groups of people to achieve results. So we've got a much broader scope than we did in 2018. Some of you are probably aware of the Supportive Communities programme that brings residents together to maximise the use of the third sector. Better Health Staffordshire is our new approach to obesity, which is very much about harnessing partners, support, bringing physical activity opportunities, the NHS, activities of the council together to try and help people to lose weight. We're developing a similar partnership approach to mental well-being, so the prevention of mental illness by, again, harnessing all the things that are available in the county. We've developed a lot of self-help approaches. We've got an app called Orca that people may be aware of, that quality assures apps, because there's a lot of apps that aren't very good, but we try and direct people to those that are, and we use social media as a very cost-effective way of reaching out to members of the public that we didn't have in the past. If we could move on. So the current contract ends next year, and the key question for us is what's the most effective and efficient use of the resources that we've got available. Obviously, resources are always restricted. We can't deliver everything to everyone, so decisions have got to be made about the extent and nature of the services that we offer. So we've been consulting with stakeholders, and this meeting is a part of that process. If we could move on. So stop smoking is still a huge issue. smoking prevalence rates are a lot lower than they've ever been, but it's still the biggest preventable cause of death and disease. And services work. There's a really good evidence base for smoking services over a long period of time. We know that people have got a much greater chance of quitting if they go through a service than if they tried alone. So always a key priority. Could move on. Weight management is an increasing issue for us. Around 2/3 of adults now live with excess weight, and the position in Staffordshire is much higher than the national averages, and is higher than most of our similar local authorities. Public Health England have got a system of grouping authorities into areas with similar characteristics, and we're the third highest among that group of 15. And we've seen that services work well when people access. Around 40% achieve the outcome that we seek, and they're relatively cheap as well. They cost about £100 per person, but the evidence suggests that the savings are much more than that over the lifetime. Could move on. NHS health checks are a statutory responsibility, so we're mandated to deliver those. Making every contact counts is training that we provide to all health and care professionals to give basic advice and guidance and information, which we think is a good use of resource. And we've developed over the last couple of years a workplace health programme to try and support businesses, to support their staff to access services. It's relatively slow to start, but it's now going well. Could move on. Social isolation and falls are the two areas that we question most. The falls service, or the falls prevention service, not to be confused with falls services that the NHS provides. There's been relatively low take-up. If you saw from the previous slide, only 73 people accessed the service last year. And the social isolation service, it was taken up well during COVID. But we do have other alternatives to help people out of isolation. It seems that a service to engage people with others is perhaps not the best use of resources. We've got the Supportive Communities programme that's trying to link people with other people rather than with a professional service. Similarly, we're developing the mental wellbeing programme. The CCG has got services for falls, and a lot of the things that do help to prevent falls, we commission in other ways through physical activity, weight management programs, etc. If we could move on. So the proposals for the new contract are to focus on fewer issues, primarily smoking and weight management, and to take a different approach to the issues that we're not seeking to continue with. As mentioned, the Supportive Communities programme, the Better Health Staffordshire, and the various other programmes that were developed, we think are a better approach to things like physical activity, falls and social isolation. By focusing on fewer issues, we can scrap the eligibility restrictions for those that we continue with, so we can increase the number of people who are going through the smoking cessation and weight management services, and that makes it much easier for referring agencies to send people to the services. It makes it a much more simple, straightforward offer and allows us to focus on those priority areas. Health checks we've got to continue with because it's mandated. Training staff for making every contact counts, we think is a very good use of resources because it costs very little and gets messages out there. And the workplace health programme we think is something that we should persist with to help businesses at this difficult time. So they're the proposals that have stemmed from the consultation that we've conducted over the last couple of months. Go to the next slide. And this is the last one. So it's just to say that the next steps, the tender starts in June, and really just to open up to the floor if there are any initial feedback, and we've also got the opportunity for individual consultation if anyone would like to talk to me or one of the members of the team outside of the meeting. Thank you.
Thank you, Tony. I've got Charlotte first, and then I'll go on to Thomas.
I do think that the eligibility restriction was a real problem. In fact, I decided to test this out. And because it was, I live in Leek North, my postcode was not included. In fact, not even the whole of the Haregate estate, which is the most deprived part of Leek, was included. So I decided to present myself to the programme. I did add a few pounds onto my weight and added on a few other health issues. They must have been a bit surprised when I actually presented myself, because I wasn't, you know, I'd added a few stone on. And also went through and put in my real postcode. And to my surprise, was accepted, despite the fact that the postcode was outside the criteria indicated. So having signed up, I then, of course, went through the programme. And I have to say I was impressed by the quality of the teaching. I was also impressed by some of the work they were doing with seated exercise and that sort of thing. I think that really did appeal to a number of people, and certainly was a good social event apart from anything else. But the problem was, I think, one, because of the eligibility criteria, I certainly was not willing to promote it, because I didn't want people coming back to me saying I presented myself and, you know, I was then turned away. That was ridiculous. So it you know, it shot themselves in the foot straight away by having that restriction. But also, I remember meeting someone on the doorstep who was massively obese, and told him about the programme. I knew he was in the right postcode, but it's about getting people through the doors, you know, across the threshold. And of course, it then ended up going to sort of GP surgeries. But again, you know, the people who we're trying to attract are not necessarily people who necessarily go to their GP. They may have health issues, but they may not be accessing their GP surgery. So we really have to adopt a much more community-focused approach, because, you know, otherwise you're not going to get to people, you know, and sometimes it's better to get to people via their children, perhaps, because they're worried about mummy or daddy dying because of their health challenges. And I just think we have to rethink how we do this. Otherwise, we're just going to be attracting the worried well. And, you know, that's not good for the programme, it's not good for the community, and it's certainly not rewarding for the staff involved, who I thought were excellent, absolutely excellent, but they weren't really getting to the people they needed to get to.
I think firstly it's good that you received a positive experience from the service, and I think that's consistent with the feedback that we've had consistently. But yeah, I completely agree with the feedback that you provided. The restricted eligibility made it extremely difficult to promote. It was a confusing criteria to communicate to the public, and our partners found it difficult to use that system as well. That was a system of allocating scarce resources, and I think we tried to include too many different interventions in the package, which meant that we had to reduce the number of people who could receive those services. I think we've learned the lesson over the last 4 or 5 years from that it's much better to focus on a smaller number of issues, do them well, promote them properly, make it much more easy to communicate, whilst at the same time finding alternatives to those other issues. I think the position, as I talked about in the slides, is very different now. We've got other ways of helping people to relieve their isolation, to get exercise and to prevent falls. So I think the recommendation that we've had and the feedback that very similar feedback that we've had from other people is that we should really get rid of the eligibility restrictions, focus on fewer interventions and make it much more straightforward. So very much agree with the feedback that you've provided.
I mean, I think if you do rely on just a few conditions, you're likely anyway to be picking up on other issues anyway. I mean, if you're talking about focusing on smoking and weight, you may well pick up on other issues about that they may be liable to falls, etc. So I think, you know, by focusing just on a few, that makes sense, because you're talking about anyway wider health issues within the programme. So I certainly support that, but unless we get people through the door, it's not going to actually succeed in any way, shape or form.
Joanna, did you want to come in on any of that? I notice you nodding significantly.
Thank you, Chair. No, I was just going to add, in terms of the referral process that people can get into the service, we don't just rely on the GPs. So the current service have got community engagement officers, so they go out into the communities, do a lot of that engagement work with groups within the community to try and build, you know, the message and get referrals from different sources other than GP practices. But we also have a big presence in terms of the service self-promoting, whether that be on social media, via posters, at events that are going on across the county, like the county show or the local events that are happening. And we get the majority of our referrals are actually people self-referring themselves. What we saw was when we changed the eligibility for weight management, the service was really effective in getting them numbers, which are presented in Tony's numbers that he showed there, you know, 4,000 people this year. And we're hoping that the capacity within the service going forward, having just those two indicators, mean that we can have about 10,000 people, which is about 5% of the people that are living with overweight and obesity, being able to access that service.
Charlotte, anything else you want to come back on? Thomas.
Thank you. I just wondered, you might not know that off the top of your head, but how much of the budget is assigned to each one of those services? And has there been any analysis, cost-benefit analysis? The one that grabbed my attention particularly was the smoking cessation one. If you had 1,000 people use it, only 15% have quit at 12 months. It could be £4,000 or £5,000 per person. What's that worth in terms of hospital spend later? Has there been an analysis where it's worth spending that money or not? Thanks.
As Jo will be expecting, I'll probably pass over to her to give a fuller answer. But smoking cessation services are one of the better evaluated parts of public health, or any parts of the NHS. They're extremely cost effective. You're right that when you look at the attrition rate of the number of people who access a service, who achieve a quit, who then subsequently stay smoke-free, that those numbers do reduce, but the cost savings associated with each quit are enormous. So we're very confident locally and nationally that smoking cessation services are very cost-effective. But I'll pass over to Jo, who'll probably be able to give a broader response on the effectiveness of the other interventions.
Thank you, Tony. In terms of the costs, just based on the modelling that I've done, it's probably about, we're looking at about £500,000 for targeted weight management and then non-targeted. So within the specification, we expect about 50% of the people coming through the service to be from targeted groups. So those are people who are living in areas of deprivation, people from ethnic minority groups, people with learning or physical disabilities, and then the other 50% from people outside of that. And again, for stop smoking, it's probably about 800,000 going to the stop smoking services, and then about 200,000 for the targeted NHS health checks.
Thomas, anything further? No. Anne Edgeler.
Thank you, Chairman, and thank you for your presentation, Tony. But I think one of the questions I think you know I'm going to ask you is, what do we do with drug and alcohol situation? How are we helping those people? Because as you know as well as I do, it's on the increase, and also mental health capacity as well. What are we doing with people with mental health problems as well? So if you could give us some feedback on that, especially for the new members, I would be grateful. Thank you.
No, thanks, Anne, and thanks for all the support that you've provided with these issues in recent years. For the members of the group who aren't aware, there's a separate system for drugs and alcohol. The service in Staffordshire at the moment is called STARS, the Staffordshire Treatment and Recovery Service, that's operated by an organisation called Humankind. And there is actually some good news on this now. The government announced a 10-year drug strategy just before Christmas, and a significant investment to go with that, around £750 million over the next 3 years. that's the good news. It's slightly qualified that the way that the funding's been allocated hasn't benefited Staffordshire enormously. They've got a staged approach where areas receive different amounts of funding in different time periods, and unfortunately Staffordshire is in the third year of that cycle. But we have still received a reasonably significant uplift in funds for this year and for the next 3 years. So the services have struggled in Staffordshire recently, although they are getting better. CQC inspected the services a couple of months ago, and they came back with a rating of good overall. Now that isn't to say that we're satisfied with the services. We've got lots of gaps across the pathway, but the funding that will come from central government will help us to plug some of those gaps, and we hope in the next 3 or 4 years to be back to the position that we have been in the past. Because as Anne, as you know, we have struggled for a period of time, but things are getting gradually better. On mental well-being, again, we're starting to pull together a programme similar to what we're doing with obesity, where we try and engage different partners across the county. The mental well-being is different to some extent than drugs and alcohol that need specialist services. There are a lot of opportunities across Staffordshire for activities for people to engage in that can help their mental well-being, but there's been very little coordination of that or collaboration between organisations. So we're trying to bring partners together to focus on key priorities and to help to engage with people to access what's out there. Because one of the key issues with mental well-being is that people aren't aware of the things that are available and what's good practice in terms of improving their well-being. So again, some encouraging signs there, but those two areas are separate from the services that we're talking about today.
I think your last point was most relevant. I was very mindful that we were off the subject of healthy communities. So can I move on? Yes. Thank you. Bernard.
Thank you. Under the question of weight management, there's two points I'd like to make. In Burton, we have a very diverse community, as you know, and a lot of Asian people. And I've spoken to them about weight management, and sometimes something's lost in translation perhaps, but I wonder whether your reach into East Staffordshire, where there is quite a predominance of Asian people who do carry excess weight at times, so how are you addressing that? And if I could just make an observation, it's a classic, this development of diabetes, you say in diabetes. Why can't you be more specific and say type 2? I am a diabetic, and I detest this generic diabetes statement. You're either a type 1 or a type 2. And I'd ask you to consider pitching your argument in the context of, well, weight management is more so related to type 2, because then that eases a bit of pressure on diabetes.
Apologies, you're absolutely right. It should specify type 2 diabetes. That's an oversight, and we need to be more accurate around that. In terms of your first point, the services do try to adapt their approach to be sensitive to different cultural traditions. I don't know, Joe, if we've got any specific feedback about what Everyone Health have done in East Staffordshire.
Not specific examples, but in the new specification, just to note that we do recognise that those from ethnic minority backgrounds do have a significant increased risk. So we brought the eligibility criteria down as opposed to body mass index for those specific groups in line with national guidance. And the service are embedded within the communities right across Staffordshire. So linked in with the community champions in Burton, and also we utilise a trailer to go round, so a rolling trailer that we used for COVID. Now the service are using that so they can get out and about in communities, start doing NHS health checks, and that starts the conversation then. If an elevated weight is picked up, then they obviously then can have a conversation about the other services that are on offer. We also do, obviously, the workplace health interventions, where we focus on routine manual workforces, where they go in, do a mini health check event, and then obviously that links to referrals into the other services. And I've mentioned before about the community events that we tap into.
Just one point, if I may, Chair. Do you have any plans to use a pathway into schools to get messages into young people at an earlier point rather than waiting for them to be 18 to get the message to them? I know you said in your opening that the pathway was to over 18s. So is there any way of getting an early intervention in with younger people, do you think, via the schools?
Yeah, sorry, I should have clarified. There's separate 0 to 19 services that include weight management. They're on a separate tender timeline, so they're not part of this cycle, but there are services for young people.
Can I just sorry, Bernard, have you finished? Yeah, thank you. Can I just raise a question in my mind that relates to yours, Bernard? Would there be some value, Joanna, meeting with Bernard separately to understand his specific experiences in East Staffordshire? Because I think that he's indicated he's got some very specific experiences engaging with those communities, and I want to make sure at least that they're reflected within the tender, if at all possible, please.
Yes, Chair, I'm more than happy to work with, cooperate, and any added value I can give.
We'd very much appreciate that. Thank you.
Thank you. Useful. Philip Atkins. Good morning.
Morning, Chairman. From the other part of East Staffordshire, the rural bit. I think I compliment Tony on the presentation, because less is more. You know, if you're concentrating on less things, you will actually achieve more. But the other side about that is that everybody involved in community work or health and local government, churches, whatever, must have the knowledge to know where to signpost people for help if they think they need it. And then that leads into, most people don't think they need help, actually. They're very stubborn about what they think they actually need. And so that leads me to something around encouragement. And I know in my daytime work in agriculture, we're starting off with a thing called the Animal Health Pathway Plan, where farmers are actually paid to have a vet in to advise them on preventative things that they can do on the farm. And so some of that is quiet. With dairy cows, that's about. Actually, they suffer from falls as well in the sheds. And if you get a cow that's down, it doesn't produce milk. There's a lot about vaccinations, prevention of illness, new diseases that they may not have thought about, getting troughs right for bovine TB. There's a whole, we've got more diseases in farming than you have in the human race, I think. But so there's a little bit about trying to encourage people into thinking about their health. And the way they do it is this: the farmer doesn't get paid, but the pathway plan is paid by DEFRA. Quite expensive, actually. It's probably anything from £100 to £500. The vet gets paid for doing the work. So there's a little bit about, I can see that less is more, but the other part of it is the signposting work, which picks up on Anne's comments about drug and alcohol. It picks up on the stuff about falls. Most people, Mark Winnington's brother fell over a couple of days ago and ended up in hospital. I saw a chap in a pub the other night who couldn't stand up because his knee had just gone wonky. So there was an ambulance and he was off to A&E at 10:30 at night. So there's all sorts of things that happen that people don't think about. And rather than focus on budgets and all the rest of it, let's focus on outcomes, because that's what it's all about, not process. Less is more, not the process, outcomes. And just to finish off, my son, in his new alternative career, will be a fully qualified nutritionist in September. And it's been quite fascinating listening to him talking about nutrition. And people going to him who want to lose weight, and it's fairly obvious. You put calories in, you've got to burn it off. And people don't just think about what they're bringing into the system, which ends up with them being overweight and obese. And on top of that, I was talking to him about somebody we both know, and he just said they're not eating enough protein. They've got a bloated stomach, cramp in the legs, different symptoms, and he said that is all to do with their diet. And I sat and thought about that particular person, and I thought, yep, they sort of don't like red meat, and they're into chicken and fish, but don't eat this and eat corn and, you know, all the rest of it. So there is something about diet and nutrition. And I'm just going to finish up on cost of living, the other bit that I keep banging on about. You know, I'm sure that people will keep in mind, but as cost of living comes along, there is a danger that people go for strange things as they can't afford to feed themselves properly. So there's something about, going back to that school thing that Bernard was on about, domestic science in schools and people being taught how to cook foods and not go to the pre-prepared meal shelves, particularly if people living on their own. It's far easier to make enough food for 4 meals and do that sort of thing. And so I think we've lost that ability to cook. So thanks, Chairman.
Thank you. Tony.
No, I think less is more is probably the strap line to this, that we need to reserve services for those that need them most and find alternative ways of achieving outcomes for other people, and that's very much the ethos that we're trying to take going forward.
Philip, anything else?
I know Tony gets the message.
Thank you. Mike, good morning.
Thanks, Chair. One of the slides that you showed us, Tony, was about the activity and outcomes. And I just wanted to try to get my head around some of the outcome targets that seem quite low. And given then that the outcomes achieved, although they were above the outcome target, are higher, it's sort of it's not as high as perhaps we'd like that to be. I just want to get some understanding as to how those targets have been set. And then on the second point, you talk about consultation with key partners. I assume that includes districts and boroughs, and I just wondered what form that will take. And then finally, Chair, just a question about what will good look like in the future? Will we expect to see a similar sort of activity and outcomes targets that we have here, or will we have some other way of being able to actually see what the achievements have been and how successful we are? And then how do we make sure that those sort of outcomes increase in numbers and the percentages are going in the right direction going forward? Thank you, Chair.
Thanks for the questions. I'll take the district and borough one first. We've spoken to various members of staff from districts and boroughs through our day-to-day activities, but we also presented at the recent Chief Execs group, and we asked the Chief Execs from each districts and boroughs to nominate a link person who we could pick up those discussions with on an ongoing basis. So we tried to take it from a formal and an informal approach, so some really good feedback throughout the process, and we've got some good relationships with the districts and boroughs, so we are speaking to some on a regular basis. In terms of the outcomes, there's some science, there's more science to some than others. So smoking cessation is the best developed of all those interventions, and over 20-30 years, good practice suggests a particular figure. Now, Joe might correct me because it's a few years since I've been directly involved, but it used to be a position where if 45% of people who access the service quit, that was good practice. 50% you were doing really well, 40% less so, based on services delivered in 150 areas across the country over 20 years. Obviously, not everyone who accesses the service is successful. The evidence base for some of the other services is less strong, and we tend to use research papers, our experience over a number of years, experience of our partners in other areas to see what that benchmark is. So it does, the level of science behind it does vary, and the key point is that we try and push services always to achieve more outcomes. I'll try and answer the third question, and Joe might want to come in because Joe is the expert on a lot of this. In terms of going forward, outcomes is key, and associating payments with outcomes to incentivise good practice is a big part of what we'll do going forward. But that voice of people is also key. You don't always feel the quality of a service from an outcome, and the key measure of quality is that feedback from clients, and that's built into the programme going forward. Joe, I don't know if you'd want to add to anything to that?
Yeah, just in terms of the stop smoking numbers that you talked about there, that nationally we do have that, but that's only on a 4-week outcome basis, whereas this service is 12-week outcomes. So we'd expect to see slightly lower, which is why we set the target at 43%. But as you saw from Tony's stats, we are actually achieving 48%, which is excellent. In terms of the weight management, the national key performance indicator for that is 30%, and we have a target within our service currently at 32%, and they're achieving 40%. So going forward, I wouldn't expect the outcome targets that we're expecting to be a lot higher than what we've got there and what they're achieving, because obviously behaviour change is difficult. Not everybody who goes through a service is going to achieve that behaviour change first time, and we do know from Stop Smoking Support that sometimes it can take somebody 7 times to go through that quit attempt journey to actually achieve it long term. So I wouldn't expect those to be going up into 70s, etc. percent, but I think the service is providing a good quality service, and I'd like to see that in the new commission. Obviously that's something that we will monitor. What we will get is the more people through, obviously the number of outcomes delivered are going to increase as well.
Anything further, Mike? Jill Hood.
Thank you, Chairman. Please excuse my back while I just direct my conversation to Tony. Through you, Chair, through my back. Thank you for your presentation, Tony. You heard Philip say that concentrating on less was probably a good thing, and yes, I do agree. But when I look at the things that you've outlined, social isolation, smoking cessation, obesity, possibly even falls, everything to me seems to point back to mental health issues. And I noted in your slides that you were talking about a programme being developed. I struggle with the quality of service and the lack of resources that are available to those who suffer from alcoholism, drug addicts, etc. They are woeful, and I speak with good authority and experience. They are woeful because the doctors seem to have a culture of referring people with drug and alcohol abuse problems to the same services, always the same named services. I'll say to my residents, well done, that's the first step. Where are you going to go to? Oh, such and such, such and such. I struggle also with how do you rate the quality of the service agency that you've sent those people to. If you're suffering from drug and alcohol problems and abuse, and I mean serious problems, I'm sure those people will not be in a position to actually rate the quality of service. Now, I could sit here all day and talk about failed appointments, long-term sick, people being let down, telephone appointments, when these people are so low down the ladder, they need face-to-face contact, friendly smile, eye contact. They're not getting it. And if you would like a private conversation about this, I'm quite willing to name a number of services that have been put forward. I really hope that we recognise and understand the severity of mental health as we've been through the last 2 years. The increase of alcoholism and drug abuse because of the last 2 years, and the fact that people are not being seen. They're not being seen in the way that they deserve to be seen. And I really hope that the mental health programme that you're talking about, the development, hurries up and comes along, and that you get adequate funding to pay for enough staff and enough resources to help these people who are really, really struggling. And I love the fact that Bernard has spoken about schools, education in schools. I love the fact that Philip Atkins has spoken about nutrition. My 7-year-old grandson has gone off for the very first time this morning on his own to a football academy. He's had protein, carbohydrate, vitamins, because I understand the absolute nature of nutrition and the importance. Sadly, we're coming into an age now where many families won't be able to afford to feed their children the correct nutrition, and mental health will be on the increase in the younger sector that we have now. So I'm sorry that I fired all that off you, but really, take my word for it. The service that's on offer at the moment, as I've said, is woefully inadequate. Thank you, Chair.
Tony, before you come in, and I did allow Councillor Edgeler's intervention outside of the scope of the paper itself, but I think it does warrant a response. But I just make one other comment, which is I think the mental health strategy is coming to committee in June. A long-awaited mental health strategy is coming in June, and I think that we will want to give it adequate time then. But please, can you just give an outline response to the points that Councillor Hood has made, please?
First thing to say is I share your concerns. I've worked in the drug and alcohol field for 25, 30 years. It's something I'm passionate about. And I think it would be useful to have a conversation outside of the meeting to get your feedback and to help with the developments going forward. There is more money from central government for drugs and alcohol, which is completely associated with mental health. We've got some really good work going with the two mental health trusts to bring the two things together, so I think it'd be useful to have a conversation about how we can develop things going forward.
And obviously that invitation potentially would be to any member of the committee who'd got relevant, pertinent information to share on mental health strategy.
Absolutely, and I think anyone who knows me knows that I'll talk at length to anyone about drugs and alcohol at any time. So yeah, very welcome a conversation with anyone who's got any interest in any of those associated issues.
Welcome that, thank you. So I've not got any other indications, so I'm just going to sort of, Daniel.
Thanks, Chair. Just like to say well done, really, for going to be taking away the restrictions, especially on the smoking cessation, because I think it's something that me and the Chair spoke about actually at the meeting that you was last in, and noting that it was going to be blocking a lot of people that really wanted to get into that service. Looking at the outcomes again, obviously that's going to be county-wide. Just looking more specifically at Tamworth, have you got any, what the uptake is in Tamworth, as it's the top of the list for obesity in the county? I was just wondering if how Tamworth ranked in the uptake for that. Cheers.
I'm sure if Jo hasn't got it at her fingertips, she'd be happy to send it to you.
I haven't got it in my brain at the moment, but we can have a look at the data and supply that.
Is that okay?
Thank you.
Can I just follow up not the specific question, but the line of questioning? Because I was interested, because I'm sure that those people who sit on district and borough committees would be interested in being able to drill down into the data for these areas, smoking, weight management, physical activity, falls, social isolation, in terms of their individual wards. And I'm always disappointed that we can't drill further down into street level, and I've banged on about this for the last 10 years, and I will continue to. But where can people access this data so they can share it with others on those district and borough committees, please?
Joe, correct me if I'm wrong, but I think the Joint Strategic Needs Assessment has got a lot of the figures broken down to district and borough level. I think anything beyond that we would need to do as a bespoke exercise, but I'm sure we'd be happy to do it.
So could you just send us, as part of this sort of wrap up from today, the link to that, because I'm sure members around this will want to take it back to your committees, either as the district lead or as the borough lead, the district or borough lead, or as the county council lead, because in the end this is a role for partnership. So that brings me on to my second question, which relates to how some of these some of these services are commissioned. Sometimes by grouping lots of disparate bits together and commissioning them across a whole wide geographical area, we don't deliberately exclude providers, but certain providers feel excluded from being able to tender for services. I specifically think, I'm thinking about falls prevention, because the best people in falls prevention terms have always been the fire service, with all the visits they've done over the years to people's homes, and they get access really easily. You know, we now have data which identifies those people who most benefit from those sorts of support. So my question is, are we better in looking at some of the other people who are providing services in these areas and commissioning in a different way to lumping it all together? Sorry, that doesn't sound very respectful, sorry. Are we better in disaggregating and maybe looking at different ways, or taking the views from existing potential providers out there to look at the best way of commissioning?
You make a very valid point, and it is something that we've learned over the sort of 20 years or so of public sector commissioning in this way. And a lot of the areas that we commission services from now, we use a prime provider model. Rather than having 5 or 6 different specialists working together, which is often really inefficient, the handovers are where you usually get problems. We commission a prime provider, but what we don't want is a monopoly of one organisation delivering everything and taking up the resources. But a prime and a subcontractor arrangement seems to give the best of both worlds. It gives you the efficiency and the coordination of a single organisation, but it allows for that diversity of services that reflects different specialisms. And that's what we do at the moment with the drug and alcohol services, Humankind's the prime, and then Burton Addiction Centre, Combined Healthcare, etc., subcontractors. And I assume, and correct me if I'm wrong, Joe, that facility will be available with the contract going forward, that we're looking for one organisation to have the contractual relationship with us to keep things simple, but then the opportunity to subcontract to specialist organisations, as we already do with things like weight management that's subcontracted to Slimming World and Weight Watchers and things like that. So I think that's the plan, isn't it, Joe, for the new contract?
Yeah, absolutely.
Thank you. My practical experience on the ground is sometimes that puts off the subcontractor who is the specialist. And I am slightly concerned, having looked at a number of commissioning rounds over many years, is that we don't deliberately exclude, but we actually happen to exclude. I couldn't see the fire service necessarily volunteering, for example, to be a subcontractor to a prime contractor. And, you know, they would be, in my view, probably the best in falls. There is already existing people doing lots of work in social isolation, for example, social prescribers. And there is duplication there. And maybe you might just want to look at that commissioning model.
No, I think you're right. It is difficult sometimes to forge those relationships between primes and sub. I think the approach that we're trying to take is to give longer term contracts as well now. That historically, the average contracts were probably 3 years. Now we're looking at doing more like 7-year arrangements with break clauses. Obviously, if a service is failing, we'd want to come out of that much earlier. But by having a longer period for a contract, it allows to build those relationships over time. So the position that we've got with Humankind, they're bringing on new subcontractors. The position at day one won't be the same position at year 7. So I think trying to create some stability that then allows relationships to be built over time, but with those break clauses if there are problems. There isn't a perfect solution, but you make some very valid points.
Thank you. Just if I can move on slightly, have we mapped all provision, not all of our provision, but all provision across communities? Because there are other partners who have a stake in some of these areas. And are we using public resource across all of those partners to best use?
That's very much the ethos of Better Health Staffordshire, which is the sort of brand name that we've given to the obesity service. There are lots of opportunities in Staffordshire for people to exercise and to a slightly lesser extent to eat well. We don't need generally specialist services for physical activity. There are lots of clubs, sports organisations, opportunities in the green environment that we've got. However, historically, we've had a lack of coordination and collaboration. People aren't always aware of what's available, how to access it. Partners have generally worked in isolation. So the obesity strategy isn't really about commissioning specialist services. It's about coordinating and creating that collaboration, identifying where the key issues are, communicating to the public what is available and how to access it, improving that information, advice and guidance, and signposting people to the right things. I think that's a much more efficient use of our resources that allows us then to keep specialist services for those who need them most. Majority of people can use other facilities that we've got in the community.
Thank you. And finally, what is the role you envisage for the ICS?
Everything's connected. It's a different part of if we think of the journey, obviously the ICS picks up people that really have, I don't want to say failed, but the people that we haven't been successful with in the prevention pathway will end up with the ICS. We are developing a joint committee around obesity. The NHS is responsible for commissioning bariatric surgery, and some of the specialist nutritional work. We're responsible for the lower threshold interventions. So we do work in partnership with them, and we are formalising that relationship. Our key focus, though, is to try and keep people away from the NHS. If we can encourage people to eat well and exercise more, hopefully that keeps people out of bariatric surgery and those specialist services.
Thank you, and I absolutely agree with you, but it strikes me that they are a potential funding source to ensure that the first and only role that we look at is prevention, and we look at intervention as failure.
Absolutely. I think they would see it as our responsibility under the public health funding arrangements to fund those services, but I think that there are things that we can do across services to support one another, engaging with GPs and other health professionals to drive people towards the prevention services are a key part of that. So yeah, there's lots of joint relationships that we have with the NHS, but also with districts and boroughs and other organisations. For things like weight management, lots of organisations have got a role to play, and that's part of the strategy going forward to try and harness that as best we can.
Thank you, appreciate those comments. I'm not seeing any further indications, so on that basis, Joanna, Tony, thank you for sharing that with us this morning. I think the abiding message that we will take away is that your intention is to increase razor-like focus and to focus in on outcomes at the same stage and improve the impacts of what you're looking to do within communities, and that as a challenge for you guys, that you look at how you improve the importance of starting early in schools.
And thank you for inviting us to the meeting.
Thank you. So I don't think we need to do anything further than note, given the input we've already given. So on that basis, can we move on to the next item? Which is I can't tell you which item number it is, but 6. It's the District and Borough Scrutiny activity. It's already noted, with the exception of, I think there was one district who was going to report, is that right? But before we go on to that, just wanted to make a reference and make mention to a move that is happening with the districts and borough colleagues, which is that we're looking to update our local scrutiny officers' way of working. So the existing way of working is several years out of date. We're just looking to update that. Nothing more for you to be aware of than we're just looking to reflect what we currently do. So anything further you want to say on that, Debs?
No, Chair. Lichfield District Council last met on the 26th of May, and we may want a verbal update if there is anything to report.
There you go. I thought there was one. Thank you. That puts you on the spot, Mike.
Thank you very much, Mr. Chairman. I've obviously just taken over the role from Councillor Latham. Our next meeting is in June. I have got an issue I did want to raise, if I may at this stage, regarding maternity services. This committee, I think, had a report back in August of last year in relation to the temporary closure of the maternity unit at Samuel Johnson Hospital in Lichfield. I don't think we've had any update since then, so we'd be very keen to hear any update, given the fact that some of the facilities at Burton have been temporarily closed due to refurbishment. The birthing pools, etc., have been closed, and therefore some expectant mothers have turned up not being able to use the facilities, although they were previously booked in. So I think there's some issues on communications there, and I just wondered whether, if that was the case and Burton not able to offer that facility, whether there was not a consideration of reopening the unit at Samuel Johnson, where there are birthing pools, to allow expectant mothers to use the facilities there at Lichfield. But we really are concerned as to what is the future of the maternity service at Samuel Johnson. So we would very much like my district an update on where we are in relation to that, given the fact that expectant mothers are now having to travel either to Derby or to other areas, New Cross or Walsall, to have their babies delivered.
Thank you, Mike.
Thank you.
I was aware of this issue because it came up last week, which I'd seen from, I think, a resident of yours or of Lichfield's. I also note that it's on the agenda for our next formal meeting. It's not the next formal meeting, it's the 1st of August meeting. And I've asked for a written response in terms of Samuel Johnson. I don't know all of the answers to be able to provide those with you today. So providing you're happy, I was going to propose to do it by written response to you, and then you can circulate to the relevant resident. And I'm sure you'll know who I'm talking about. Okay, Phil Hewitt.
Hi, Mr. Chairman, just to keep you up to speed. AGM at Cannock District Council last Wednesday meant that there was a change in representative on this committee to, or the Scrutiny Committee, to Philippa Hayden, well known in this parish. I spoke to her this morning and she said she hadn't received an invitation. Almost certainly that information wouldn't have come through by now. So just to check that happens.
Thank you. We note it. We hadn't been notified, but we will make sure that is picked up going forwards. There is some communication going on regarding the Cannock Minor Injuries Unit, as you'd expect, and I'm not at liberty to say anything more on that because we're in a tender process. But we will pick up that separately. Thank you.
Yes, I was going to add to that. Councillor Hayden will, of course, join my campaign to make sure the MIU unit is open and useful in Cannock.
Thank you. I don't think I'll add anything further to that. So on that basis, I think we have concluded item number 6. We have. So let's move on to item number 7, which is the forward agenda. So the work programme. Without wanting to delay conclusion of this meeting any longer, I just want to highlight to members that this is the opportunity to flesh out the work for the next year. And if we don't spend time doing that today, the danger is that the things that are important to our residents or potentially cause the greatest harm to our residents don't get the appropriate scrutiny. I'll come to you, Charlotte, in a minute. So I would encourage an appropriate review of the data which is in front of you. However, I did want to raise three things, and then I'll come to Charlotte if I may, please. The first thing I wanted to raise was I think there is a need for us to have a formal way as a committee of looking at items for scrutiny. For example, are we looking at them based on risk to our residents, or auditing the processes that the NHS go through within a patient's journey? Because we could spend a lot of time with the variety of institutions that sit within the NHS, bringing them in front of committee and not scratching the surface and pretending that we have given sufficient assurance that those organisations and areas are working to the best possible way. Good example of that, I'll come to you, Philip, after Charlotte. A good example of that would be some of today's discussion. You know, do we know, for example, which of the specific specialisms that are working outside of the 104-week waits? I would suggest that we probably aren't today. And so as a result, when people come in front of committee and we say that we have reasonable assurance, looking at it from an auditing point of view, that we have reasonable assurance that things are going well, have we done enough detailed digging into the subject to know that's the case? So on that basis, what I'm going to suggest is that we look at creating a framework for us to be able to ensure we spend the valuable time that we have on the most important issues for us as a committee and for our residents, both in terms of the mass that people go through, the mass pathways that people go through, but also those on the furthest periphery, you know, those most furthest away from healthcare systems. So I'm going to suggest that I pull together a framework that we put up for debate and we look at it next time round. And you'll notice on the forward work programme that we've actually put in an extra column which tries to indicate which is the area of our concern. Because I'm going to suggest that going forwards we need to make sure that we have a question that we want answering from our guests, and that we stick them to we stick very much to the question. No issue with going outside of the subject area if we think it's relevant and adds value, but not if it doesn't, but that we actually get further into the detail. So conceptually that's a bit sort of a bit of a challenge for everyone in this room, including myself, but I think it's a journey we need to go down. I've recently held meetings with the Department for Health, and I know that there are a number of other scrutiny committees across the country looking at doing the same to ensure that, you know, we get no surprises. That is probably one of the measures of success from a scrutiny perspective for this committee. That's the first thing I wanted to raise. Can I just take any questions or concerns that people have got in what I've just talked about, and then I'll just move slowly on, if I can. Philip was, let's start with Charlotte. Was yours on this issue specifically, or can I bring you in a minute?
Adding something to the work programme?
If I can. Philip.
I agree, Chairman. This has become a committee that just audits NHS process. Sorry, that's what my view is. It's not a scrutiny committee. Scrutiny committees are very difficult to manage, but they should be looking at a subject, investigate, get the evidence together, come to some conclusions, and then make some recommendations to the council, the local authorities, or the National Health Service. We seem to have been almost, and I've said this before, if you're not careful, you'll end up getting blamed for anything that goes wrong in the NHS, because they'll say, well, we took it to scrutiny, and they said it was all right. So I agree completely with what you've just said. We've got looming, looming things that are coming along with the cost of living and everything else. And we should be by now thinking about that's going to happen. Come to some conclusions about how families can be helped, and that's not necessarily put more food banks or more processing or something like that. It may be that they're educated in how to cook fresh vegetables, for example, rather than buying frozen or pre-prepared food. So there's something that in what you're saying that we've been doing, and I've been saying this for 18 months. So I agree with you, but I think I was in a rural services network about bus services the other day, and everybody knows that bus services in rural areas aren't that good and all the rest of it, but it just got bogged down in process. It really got bogged down in process, not about and rattling the tin for more money, which wasn't going to happen. There was no discussion about hubs and spokes, alternatives to Royal Mail having post offices in the vans and then carrying people to other villages. No mention of hospital volunteers taking people in, nothing. It just all got bogged down in process. And I'm sorry, we've just had a meeting of process today.
Thank you for your input, Philip. I appreciate that. I would have said evolution rather than revolution. You feel like, to me, a revolutionary today.
I'm a revolutionary today, but I'm a great believer in evolution, but sometimes you get fed up with kicking the tin can down the road and you kick something else.
Thank you. Good. So do we want to take other people's views in terms of what Philip said, my softer alternative? What are people's thoughts? Shall I provide the framework and then we can discuss that at the next meeting? Is that the best alternative? Good, thank you. Seeing lots of nods, let's do that. So let me bring Charlotte in now.
I would like us to be looking at dental health because that comes within the public health agenda. It is not focused on either by the NHS or by us as a county council. It highlights inequalities. It's increasingly becoming a private health service rather than a public health service. And we're having a situation where people, particularly people new to an area, but also people who've been dropped off NHS dentistry lists, cannot get any NHS dentistry and literally are being given the choice of no service or having to spend what can be hundreds of pounds to get a service. So I do think this is something which we haven't looked at a committee for a very long time. And I think it is something which, certainly from my experience in my division, is increasingly a problem.
Thank you, Charlotte. My understanding is that dentistry is transferring into the ICS in terms of commissioning, and that's happening as of March 2023. I think there are some elements transferring in advance of that. Is that?
Yes, we're awaiting for Peter Axon is actually coming to the next meeting for an ICS update, Chairman. So we should be able to get an update on what services are transferring and when.
I mean, just to say that it took a very long time for dental health to be included in the original framework for health and care. It was very much an afterthought, and it was sort of added on, as I said, as an afterthought. And what I don't want is for dental health to be yet again an afterthought in integrated care. It impacts on people's physical health, their mental health, their ability to have confidence, applying for jobs, presenting themselves for interview, etc. If you have very bad teeth, it can create all sorts of problems from very young age to old age. And I do think it's something which we should take seriously.
I absolutely agree with you that we need to take it seriously. It's obviously on the work programme and it hasn't been scheduled yet. I think the question in my mind is how we schedule it, knowing that there is a move within the NHS. Maybe could you just drop me a couple of questions that you want answering within dentistry, so that we're focused, first of all, on the areas of greatest concern. And then we can discuss that with Peter Axon at the next meeting, particularly, to see whether when the appropriate time to bring that to committee is. The issue I've got is this transfer from where they are currently commissioned to the ICS. That's the issue that, you know, there's no point in bringing it if it's all going to change. That's my concern. Phil Hewitt.
Thank you, Mr. Chairman. I don't know whether this is appropriate, really, because as a lot of us are active members, we go into the community and visit community groups, and that's when I find that I get my best feedback. So last week, Councillor McMahon and I visited a sort of children's centre in a highly deprived area of Cannock Chase. It's been there 26 years. It's incredibly successful, and it's a good way of catching up where our challenges are. And one other thing they brought up quite quickly was their health visitor service. Now, I don't know whether that can be looked at, whether it can't be looked at, but they were telling me how difficult it is to get a health visitor. Now, that really surprised me, because me and my late wife, we fostered babies, so we had lots of babies, about 12 years of babies. And the health visitor literally used to come within 2 to 3 days of the baby arriving, give all sorts of really good advice, and it was a fantastic service. Now, in my ignorance, I actually didn't realise that service had deteriorated so much, or the voluntary group were suffering some particular problems in that area. So maybe that can be looked at, Mr. Chairman. I'm happy to drop you a few lines with the challenges. And the other one, and I'm sure we all agree, I have loads of feedback about the ambulance service. You know, 8 or 9 hours. I think when we had a discussion no more than 2 or 3 meetings ago, you know, when somebody brought up there was a 9-hour wait for somebody lying on the floor, and they didn't go, oh, this was terrible, it was a one-off. They went, oh, okay, there wasn't. So going back to what Philip Atkins said about sort of a bigger challenge in there as to how they're going to solve some of these problems, particularly on the ambulance service, because at my age I worry that I might need one sooner rather than later, and it's not going to turn up. So it's always a personal point of view, but those things concern me. I may be slightly off-piste, Mr. Chairman, but they still concern me.
Thank you, Phil. Just in terms of order, happy to receive some notes in terms of health visitor service. I think we all share the same concerns on the ambulance service, albeit I think my view would be, and if we went back to the December meeting where we looked at the system, the problem is that all parts of the system are creaking and breaking point. And the difficulty is that the front end to the system is the ambulance service. So it's very easy to focus on the ambulance service when the reality is actually it's the marginal gains through all parts of the service. We do have a review scheduled for September for the system review, and that to me is the important piece. You know, where are the actions being delivered across the whole of the system? I have seen some stuff from West Midlands Ambulance Service, which suggests their service is at breaking point, and that is something that, you know, I'm extremely mindful of. But I would go back just to saying, actually, we need to make sure that all parts of the system are working together, which was the importance of the question that we asked Helen at the end, which is what were the learnings from the critical incident being called in Stoke?
Thank you, Mr. Chairman. I think we're on the same page.
Thank you. And it certainly won't come off this radar either. So, just 2 other elements not on the papers in front of you. One is, bearing in mind my initial comments to this item, women's health is something that I think a number of people in this chamber feel very strongly about. And I know that Janice Sylvester Hall has mentioned this a number of times. One of the difficulties, in my view, in trying to schedule a session on women's health
And my view is it probably isn't a session because the breadth of it is, as a discussion area, is so wide, is knowing what question to answer. And bearing in mind what Philip Atkins has just said, I don't think we can just have an agenda item, women's health, because frankly, we will scratch the surface and not of the subject and not understand the detail that goes around it. So I'm going to suggest that we task Janice, plus anyone else who wants to join her, as part of a working group to formulate what those questions are. I've had a chat with Janice. She seems happy to be able to do that, given that she's already raised it. Are there other members of this committee who would like to work with Janice to thank you, Patricia? Anne? Anyone else? Thank you, Barbara. Anyone else? That's fine. I will let Janice know. Sorry, are we all in agreement with that course of action? So are we in agreement with that course of action? Yes. Yep. I will let Janice know that's the course of action. And then hopefully between now and the next meeting, you'll be able to meet on Teams and just have that discussion so that we do exactly as Philip Atkins has just indicated, which is to make sure we are very, very specific about what is the question we're trying to answer. And there may be a range of questions, but equally that may be over a number of months and meetings. Okay. Final one I just wanted to pick up before I go on to updates is we've talked about innovations, and from an overview point of view, we've not really done much on innovation. And I was going to propose that we look to do some work with partners, potentially Staffordshire University, to ask them to host an innovations day whereby we invite a range of potential suppliers. They put up some exhibition stands and run an exhibition so that members can go around the stands and talk specifically to a range of suppliers. And then we get the suppliers to present maybe 10 minutes, 15 minutes about what they're doing in innovation terms and how that impacts on the patient and the patient's journey. If we think that's a good idea, I can start putting that in motion. Philip.
I was going to just throw a ball up in the air and just ask a question of the committee. What would be the biggest game changer to the health of people of Staffordshire? Because we tend to look at the outcomes, what comes out at the other end, and then end up saying smoking, obesity, heart attacks. But what would be the biggest game changer to stop people getting into that position? And I'll always say education, education, education. Parroting Tony Blair, but there must be something to get people into thinking healthy.
You could add in housing.
Sorry, Charlotte, I missed that.
Housing would be the key factor.
Ian.
Yeah, spent a few days actually in another part of this country doing some work for my son. And the one thing I did notice when I went there, lack of litter, right? I'm walking the dog. The bins are anything from a mile to half a mile apart, which is totally around my area, they're 10 yards apart. The one thing that was different, there were no takeaways, there were no off licenses. Now, you just said what's the difference in obesity and everything else. As a council, we give planning permission for people to open takeaways. Well, so, yeah. How many are we allowing in one area? And when this chap was just here on about areas that got obesity, I'd love to know how many of the takeaways, supermarkets, off licenses there actually is in the worst areas to the best areas. Because we can actually do something on the ground floor. It was done a long time ago. Longshanks used to say that you could only have two sorts of businesses within a mile of each other. And that was in the 1200s.
I've got Mike Wilcox first, then Philip. Oh, you carry on. Don't cede to Philip.
Chair, before Councillor Atkins, please. Another item that I would like perhaps us to consider further, Chair, is the NHS visual impairment services. I think there's some good things that are going on in around the districts and boroughs, and I think an update from them as to where they see themselves in the support that they're giving and the referrals they're making to districts and boroughs, we could certainly make sure that that is an area that we still have an importance to consider, and I don't see it anywhere on the work programme.
Thank you. Philip.
I was going to say, it's interesting, even me just saying what would make the biggest difference, and Charlotte saying housing, and Ian saying takeaways and whatever. They're both things that districts and boroughs have significant contribution to. And, you know, and the housing associations that we've got, I know Ursula Benyon over at Trent and Dove would certainly acknowledge that housing has got a key role to play in this, and I'm sure the other housing association, you know, Shinard, Butterswood as well. So that there is something that we can do, but we're getting bogged down in process, Chairman, and NHS, and we're not doing it. We're not looking at our own houses and sorting it out.
I would say declaring an interest that actually from a borough point of view I think some of the boroughs are. I wouldn't like to speak on behalf of all of the boroughs.
But it's not it's not evidenced here.
But I was going to come to that now, Philip. Everyone should have in their diary the next, it's not a formal meeting, but the next scheduled meeting, which is the 21st of June, which is being led by Councillor Edgula, which is focusing on the wider determinants of health. And I would hope that if the outcomes from that meeting weren't something that, you know, everyone took back to their districts and boroughs, that would be disappointing. It would also be disappointing if we didn't talk about housing. It would be very disappointing if we didn't talk about planning. It would be very disappointing if we didn't cover some of those big areas that affect healthy life expectancy. And actually, it'd be good if we moved away from talking about life expectancy to focusing on healthy life expectancy, because frankly, I don't think anyone signs up to spending more years living unhealthily. And if we did one thing as a committee, that would be a significant step forward. That meeting is on, is it Tuesday? Is it a Tuesday? Yeah, the 21st of June at 2 o'clock. So I'd encourage everyone to come to that, please. Just in terms of changes to the existing schedule, since it was being printed, we have Peter Axon at the next meeting talking about the Integrated Care Partnerships, Integrated Care Board and the Integrated Care System, which will come into place as of the 1st of June as a statutory instrument. Lynn Miller's talking about access to primary care, GP access. And we will have an update in terms of the maternity transformation that we've already discussed. We also have the ICS transformation, George Bryant Centre. The original item that was going to be related to maternity has been moved to September because that fits the existing consultation within the maternity services. And the same is true of adult social care reform and the impacts to Staffordshire County Council. The same is also true of the supported living services within the County Council. Mental health strategy. Debs, where are we up to with that?
We're still awaiting for the mental health strategy to be completed and released. We have a session scheduled to cover that area, plus mental health with children, which was delayed from our October meeting. So we're waiting for the timelines for the strategy to be released, Chair.
Thank you. Not ideal. Not ideal. I don't think we took a view in terms of the Innovations Day, did we, having thought about it? Are we in favour of bringing some suppliers in, maybe inviting some of the partners that we interact with to try and persuade them that they actually might want to look at some of the alternatives that, if they're not already doing so, that might be in front of them? Are we in favour of that? Okay, I'll set that up and then we'll look to do that during September probably. Okay, I think that brings us nice and neatly on to the end of the meeting. So on that basis, thank you for your challenge and input. Thanks.